Is it moving?
Yes.
Okay, so what are our objectives or intended learning objectives or ILOs? See, here our case is concerning mainly our Hatim was having diabetes mellitus and its complication. And among all the complication, the renal complications were very predominant for the Hatim. Okay, so before going to the topic proper about the renal complication of diabetes mellitus, we must know what are the basic manifestation of the renal diseases. How will you say that your patient is going to develop or his sign and symptoms are indicating that his kidneys are affected? Okay, so what are the basic manifestation and what are the different causes of the renal impairment or renal failure? Then when you go about the deep structure of the kidney, you'll find the basic unit of kidney is nephron. And in the nephron, you have glomerular. They play a very important role. So there are a majority of the diseases of the kidney affect the glomerular. But we don't, there is one lecture is required for the one single disease, okay? But we don't have that much time to discuss glomerular diseases. We'll just see a brief introduction about the glomerular diseases. Then we'll come to our topic related to the case, diabetic nephropathy, where you have its introduction, pathogenesis in the morphology, classification of diabetic nephropathy stages, then epidemiology, risk factors, what is proteinuria, why proteinuria is highlighted over here, that we are going to discuss screening and treatment goals. Okay. So,
Doctor,
yep.
can you send the lectures, please, before you
Okay,
start?
I will send it to the Rami. Okay, just 1 second. Okay. Okay, I send the lecture to the Rami. Okay, you can take it from him. Okay, the slide is clear. Is it visible?
Yes.
Okay, so this is our objectives. Now we'll go to the clinical manifestation of the renal diseases. There are two very important and broadly classified. We classify various renal diseases in these two syndrome, nephrotic syndrome and nephritic syndrome. Okay, nephrotic and nephritic. We are going to discuss, see what are the main features and difference between these two syndromes. Okay, then majority of our patient who has the renal disease in the initial stages they remain asymptomatic. Okay, and sometimes they might present hematuria. What do you mean by hematuria? Presence of blood. This hematuria can be macroscopic, where a patient see that he peed the blood in his urine, or it could be a microscopic. He or she give urine for some different examination, and they see there is a microscopic presence of RBCs. So hematuria also a very important manifestation of renal disease. Then we have proteinuria. This proteinuria is mainly non-nephrotic. We'll also discuss what is going to be the nephrotic proteinuria. Okay, so this proteinuria is minimal excretion of the protein in the urine, and What are the causes of this? We can find non-nephrotic proteinuria in the IgA nephropathy, Alport syndrome, then mild and early presentation of other glomerular diseases, other diseases affecting the kidney such as hypertension and diabetes mellitus. They will have a non-specific excretion of the protein and mainly albumin. Okay, then we have another manifestation is rapidly progressive glomerulonephritis, which is also known as RPGN. It is a very rapid, a catastrophic event, like your patient develop some kind of renal manifestation, and within a days or week he developed a classical syndrome of the nephritic syndrome. Okay, a classical manifestation of the nephritic syndrome. So here the manifestation is very rapid, so that's why it is known as rapidly progressive glomerulonephritis. Then you have acute kidney injury, or we also call it as an acute renal failure, where there is an abrupt onset of renal dysfunction. Okay, and it is characterized by the increase in the serum creatinine with oliguria. Oliguria means decrease urine output less than 500 ml per day, and anuria is the decrease urine output. Some book says less than 300, some book says less than 200 ml per 24 hours. Then we have chronic kidney disease, where there is a progressive scarring or progressive like derangement of the renal function test. Okay, and we have the end stage renal disease. Okay, we have where there is a irreversible loss of the renal function, and in that stage your patient will require either dialysis or renal transplantation. Then you have a homework. What is azotemia and uremia? Okay, what are the difference between azotemia and uremia? This is a homework for you. This is a very common terminologies used in the medicine, surgery, pediatric department when you go uremia and the azotemia. So now we go to the, as I told you already, we are going to discuss what are the differences or the presenting manifestation of the nephrotic and nephritic syndrome. Okay, so we have here in the nephrotic syndrome, you have massive proteinuria. What do you mean by massive proteinuria? The more than 3.5 gram of the protein excreting per day, and this range is known as nephrotic range, more than 3.5 gram per 24 hour. This is known as the nephrotic range of proteinuria or the massive proteinuria. So when there is a high amount of protein is excreting in the urine, so your patient will have hypoalbuminemia. So his albumin level in the serum will be less than 3 gram per deciliter. Albumin is very important to maintain the osmotic pressure of the body. When it is lost, your patient will present with the generalized edema. Other associated manifestation for the nephrotic syndrome, there is some metabolic abnormalities of the lipid. So your patient will have hyperlipidemia and excessive excretion of the lipid in the urine, which is known as the lipiduria. So this is about the nephrotic syndrome. What do you see in the nephritic syndrome? Here you have the basic manifestation is hematuria, mild proteinuria, hypertension. These are the three manifestations. Hematuria, hypoalbuminemia, mild proteinuria and hypertension. There is always the protein level is never going to this range. Whenever this range comes more than 3.5 gram, you call it nephrotic syndrome. Whenever it is less than 3, that is known as mild proteinuria, along with that hematuria and the hypertension. Some patient may also have hypoalbuminemia, edema, and oliguria. Oliguria means reduce renal urine output. So you will have reduced glomerular filtration rate, increased level of serum creatinine, and increased level of blood urea nitrogen. So this is the main differences and between the nephrotic and the nephritic syndrome. You call it differences, or you call it the manifestation of the nephrotic syndrome and the manifestation of the nephritic syndrome. If someone asks you, mention three characteristic manifestation of the nephritic syndrome, so it is expected from you to write hematuria, high, mild proteinuria, and hypertension. These are the three very, very important. But if you write oliguria, mild proteinuria also, you will not lose the marks. But a good student will always write these three things: hematuria, hypoalbuminemia, and the hypertension. Okay. So, what are the causes of nephrotic syndrome? We are discussing nephrotic syndrome. We are talking about this. We must know what are the causes. So, you have these two causes: focal segmental glomerulosclerosis in the adults. So, this is one of the very, very favorite questions in the pediatric, in the general medicine, sometime in pathology, and your SMLE and USMLE exam. The big scenario will be there, but you must look for the age group. Whenever it is adults, the most common cause for the adult is the focal segmental glomerulosclerosis, FSGS, while the most common cause in the children is minimal change disease. Okay, these are the two important cause for the nephritics. And other important cause is the membranous nephropathy or membranoproliferative glomerulonephritis. These are the primary causes of the kidney. There is also, as a complication of the systemic diseases such as diabetes mellitus in the later stage, can also present as a nephrotic syndrome. So here you have to remember the most common cause in adults is FSGS, and most common cause in the children is minimal change disease. If you don't find these two options and the age, then you look for this option: membranous nephropathy or membranous glomerulonephritis. Okay, so this is also another common cause for the nephrotic syndrome, but always look for these two causes. Okay, even though you have got all these four option in your question, and your question has been asked what is the most common cause of the nephrotic syndrome in adults, your answer should be focal segmental glomerulosclerosis. You should not say that all the four options are there, so this question is wrong. Okay, so look for the adults, look for the children. If these two causes are not there, you look for this third cause, membranous nephropathy. Okay, so you have the presentation. The patient will have generalized edema over the body. You have see the puffiness of the face, petic edema of the extremities, ascites, pleural effusion, pericardial effusion, or sometimes the entire body will look like edematous. And this condition, when there is a generalized edema, we call this as a anasarca. 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 Okay, so that is generalized edema, also a manifestation, especially in the children. You have this kind of manifestation. Look for the option minimal change disease. Okay, so what is the pathophysiology of the nephrotic syndrome? So, whenever there is a structural and physiochemical alteration in the glomerular capillary wall, there is increased permeability to the plasma protein that will lead to the heavy proteinuria, which in turn lead to the decreased serum albumin that will lead to the hypoalbuminemia. These hypoalbuminemia will cause decreased colloid osmotic pressure, decrease in the plasma volume, increase decrease in the glomerular filtration rate. With this compensatory, there is increased aldosterone secretion that will also lead to the increased sodium and water retention. Decreased colloid pressure also will lead to the fluid accumulation in the interstitial spaces that will lead to the edema and the generalized edema known as anasarca. So there are two mechanisms. One is this one, decreased hyperalbuminemia causing decreased colloid pressure in fluid accumulation in the interstitial spaces, edema. This will in turn lead to decreased plasma volume, decreased GFR, increase aldosterone secretion, and aldosterone, causes sodium and water retention. Again, there is edema. What happen in the liver? Liver is, there is a compensatory synthesis of the lipoprotein. So there is increased catabolism. Okay, that will lead to the hyperlipidemia, and this will, whenever there is a hyperlipidemia along with protein, this lipid molecule also will leak through the glomerular capillary wall. That will lead to the lipiduria. Liver also tried to synthesize albumin, but it failed to compensate the loss. So there is hypoalbuminemia. So this is the basic pathophysiology or basic pathogenesis of the nephrotic syndrome and different manifestation of the nephrotic syndrome. While we go to the, what is nephritic syndrome? Nephritic syndrome is usually acute, and it is most commonly caused by the inflammatory lesions of the glomeruli. So there is proliferation of the glomerular cells. There is also infiltration of the leukocyte or WBC, especially neutrophils. And what are the causes? We have post-infectious glomerulonephritis, crescentic glomerulonephritis. The another name for the crescentic glomerulonephritis is nothing but the rapidly progressive glomerulonephritis. So post-infectious is also known as post-streptococcal glomerulonephritis. You must have seen your microbiology lecture. The streptococcal group B infection causes two things. One is rheumatic fever, and the second one is post-infectious glomerulonephritis. There is also secondary causes like systemic lupus erythematosus or SLE and autoimmune diseases. What happened over here? There is injury to the vessel wall. This injury to the vessel wall will lead to the excretion of the blood in the urine. There is some hemodynamic changes which will lead to the low GFR. Low GFR will activate the aldosterone, that will lead to the fluid retention. There is also oliguria and azotemia. Okay, azotemia is biochemical abnormalities where there is an increased serum creatinine and urea or blood urea nitrogen. There is also hypertension. Hypertension is mainly because of the fluid retention, and this fluid retention will causes decreased GFR, and this raised GFR will lead to the activation of the angiotensin renin pathway, and there is a renin release, and that will in turn lead to the hypertension. So this is the manifestation of the nephritic syndrome. So now we go to the failure, renal failure. It could be pre-renal, renal, and the post-renal. Pre-renal, like shock, wherever there is a like hypovolemic shock or septicemic shock, or there is other organ failure like liver failure or cardiac failure. Renal causes like intrinsic renal diseases, like diseases of the glomeruloid, diseases of the tubular interstitial architecture, or post-renal whenever there is obstruction to the urine flow, like stone, or like there is prostatism or prostatic enlargement, tumors, sometimes dysfunctional bladder due to the neurological abnormalities, stroke or multiple sclerosis, or whenever if the blockage in bilateral, that will lead to acute, or that will lead to rapid failure of the kidneys. Okay, if unilateral, adult kidney will try to compensate to some extent. So far it is clear? You are following me?
Yes,
Yes,
doctor.
Okay. So now we are talking about so much about the glomerular injuries, glomerular injuries. So to know or understand the glomerular injury, you must know the glomerulus network. Okay. So what is glomerulus? Is nothing but the network of the anastomizing capillaries. So these capillaries form a network. There is also some mesangial matrix, mesangial cell, epithelium, endothelium, Bowman stage, and this will help in the filtration of the blood or plasma to excrete the toxic products. Okay, so that will or formation of the urine. So we have parietal epithelium, which lines the urinary space or the Bowman space. We have the visceral epithelium, which has the podocytes, food process which the food processes of the podocytes are embedded and very adherent to the glomerulus basement membrane. We have endothelial cell, that is a thin layer of the fenestrated cells that lines one side of the basement membrane. You in the basement you have the basement membrane. One side is the endothelial cells, another side is the podocytes, where the food processes are the strongly attached to the basement membrane. Okay, and the glomerular basement membrane is made of the collagen 4, laminin, fibronectin, and other proteins. Sometime in the histology, they might ask you which type of the collagen is most predominant in the glomerular basement membrane. So you have collagen 4. Which protein is most commonly seen? First, you look for the laminin, okay? And then after fibronectin. So the laminin, collagen 4, laminin, fibronectin, okay? These are the then you have mesangial cells in the mesangial matrix which support the glomerular architecture. So we have these are the list of the glomerular diseases. What are the primary and the secondary? Primary diseases are the minimal change disease, focal segmental glomerulosclerosis, membranous nephropathy, acute post-infectious, membranoproliferative, IgE, dense deposit, C3 glomerular or C3 is the complement 3 glomerulonephritis. While it is when the glomerulopathies are due to the secondary to the systemic diseases, you have SLE, diabetic nephropathies, amyloidosis, glomerular secondary or multiple myeloma, good pasture syndrome, microscopic polyangiitis. So these are the big list for the secondary and the big list for the primary. But you might get which of the following is not a cause of the primary glomerular disease, which one of the following is the most common cause of the secondary glomerulopathy. So you must remember at least few initial 1, 2, 3, 4, 5 options in both the chart. So what is the pathogenesis of the glomerular injury? Why the glomerular get injured? There are two types of injury. One and the commonest one is the immune mediated, immunological, where we have the antibody mediated and the cell mediated. In the antibody mediated, you have the antibodies directly acting the glomerulus, which is known as the in situ immune mechanism. While in this other thing is the circulating immune complex. You have some autoimmune disease where the immune complex are forming in the circulation, and from there they are going and getting lodged on the glomerulus. Non-immune mediate, you have genetic, metabolic, ischemic, or toxic. So antibody mediated glomerular injuries. Okay. When there is in situ, you have the in situ binding of the antibodies with or without immune complex formation. There is sometimes they find immune complex in the glomerular itself, or sometimes they directly bind to the various receptors on the glomeruli. So we have antibody against the antigen on podocytes. We have antibody against the glomerular basement membrane. Okay, so what is the example for the podocyte? Where you find the subepithelial complex formation, and this is most commonly seen in the membranous glomerulonephritis or membranous nephropathy, and it is due to the deposition of the megalin. Very, very important. Last time the question has been asked about the megalin and is not written over here. So you write megalin, the deposition of the protein which is known as the megalin, 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 megalin. Okay. Sometimes the antibodies bind to the glomerular basement membrane directly, and they is known as the anti-glomerular basement membrane glomerulonephritis. Okay. There is no immune complex formation over there. The antibodies directly binding to the glomerular basement membrane. Okay, it will show as a in the immunofluorescence as a linear immunofluorescence. You'll find a line of immunofluorescence or green color fluorescent line when you look kidney biopsy under the immunofluorescence microscope. So you have circulating immune complex. They can be subepithelial or they can be subendothelial. Okay, they can find below the endothelium or they can be above the endothelium basement membrane, below the epithelium, or they may also include bind to the mesangial cell or mesangial matrix. So this is what you see the granular over here in the when you have the antigen antibody complex, you have the granular immunofluorescence. While when you have the antiglomerular basement antibodies binding directly to the basement membrane, you see the linear immunofluorescence. With this immunofluorescence has made very easy to diagnose the specific glomerulonephritis, and we can, once we diagnose specifically, we can initiate the treatment accordingly. So circulating immune complexes can be endogenous and can be exogenous. Endogenous is mainly systemic lupus erythematosus. Exogenous because of the viral, bacterial, parasitic infection. Sometime you don't know that. Okay. After deposition, they cause injury by activating the complement, and they also recruit or bring lot of leukocyte. These leukocytes will also further secrete cytokines, and that will aggravate the injury. There are two types of immune complexes: large size, we have some endothelial and inflammatory. When the small size, you have subepithelial and non-inflammatory. Okay, so this is what we have, various manifestation of the circulating immune complexes. So you have in situ binding of the antibodies. When they go and bind directly over the glomerulus. When you have the podocytes, you have hemiannephritis, or you call it is the membranous nephropathy, where the antigen is known as megalin. Okay. The second is GBM. When they bind to the glomerular basement membrane, they causes good pasture syndrome. Always remember good pasture syndrome, glomerular basement membrane. Very, very important question comes from these 2 points. From the megalin, from the anti-GBM antibodies seen in the good pasture syndrome. What type of antibodies seen in the good pasture syndrome? Glomerular basement membrane. Okay. Sometimes we have extrinsic. They come from the endostrepsin from the streptococcus group A, endogenous from the DNA or some other case. Sometimes they also come from the endogenous immunoglobulinous aggregate when they deposit in the mesangium. Good pasture disease, anti-GBM antibodies causes a severe form of glomerulonephritis, also known as rapidly progressive glomerulonephritis. What happened in the good pasture syndrome? You have when there is an antibody cross react with the basement membrane of the lung alveoli and the kidneys. So they have a triad. You have pulmonary hemorrhage, you have rapidly progressive glomerulonephritis, and anti-GBM antibodies. When you have these triad, you call it good pasture triad and good pasture syndrome. So this is not to go in much detail about. Then we have ischemic or toxic type of non-immune mediated, where you can have the glomerular injury due to the drug. Most important, NSAIDs. So whenever you see your patient is having diseases which can affect his kidneys, such as diabetes, hypertension, you must avoid the use of NSAID, or your patient gives history of any renal disease, must avoid NSAIDs. Then certain chemotherapeutic agents, toxins, heavy metals, pesticides, and ischemia. Ischemia, whenever there is renal artery stenosis or any condition which lead to the reduced blood supply to the kidney, that may cause injury to the non-immune mediated injury to the glomeruli. Metabolic causes for the non-immune mediated, you have diabetes, hyperlipidemia, amyloidosis, gout. In the genetic, you have like there is what you call it is the activation of the alternate complement pathway. So just you remember only in the genetic non-immune mediated glomerulonephritis known as dense deposit disease, and there is activation of the alternate complement pathway. Only these 3 points is enough for you at your level. Someone wants to know the detailed explanation, they can read this, but The genetic non-immune mediated glomerulonephritis, another name is dense deposit disease, and where you see the deposition of the alternate complement pathway. So this is a table where you have a lot of diseases name, what is the most common clinical manifestation, what is the pathogenesis, and what you see the light microscopy. You see, this name is minimal change disease only because when you see the kidney biopsy in the simple microscope or under the simple light microscope, you will find no abnormalities. So you call, but your patient, your child have like proteinuria, nephrotic syndrome, and kidney biopsy shows no abnormalities. Okay, so you label it minimal change disease. You send for the fluorescence microscopy. You don't find any immune complex deposit in the fluorescent microscope. But when you send to the electron microscopy, you will see the effacement of the food process. Okay, there is loss of food processes which are tightly embedded in the glomerular basement membranes. That is loss. So this is the, whenever you take the kidney biopsy from a patient, the surgeon always take three biopsies. One he sent for the light microscopy, another he sent for the fluorescence microscopy, and the another goes for the electron microscopy. If he cannot be able to take three, at least he must take two. One for the light, with the light he can do the fluorescence, and the one definitely for the electron microscopy. So these are the diseases and these are their microscopic feature. What you say, this is a big table, what do you want to know, how do you want to know? So I see, just look for the minimal change disease, focal segmental glomerulonephritis, membranous, anti-GBM disease. Okay, these are the important one you have to remember at your level. Okay, so the spectrum, you have a lot of diseases: minimal change, focal segmental, membranous, diabetic, mesengiocapillary glomerulonephritis, post-infectious, small vessel, anti-GBM, IgA, SLE. So where you have the massive proteinuria in the minimal FSGS and the membranous. While the patient goes to this side, MCG and post-infection small, here you will find the nephritic range of, no nephrotic range of proteinuria. So what is minimal change disease? It is relatively benign disorder in children 1 to 7 year. Most frequent cause of the nephrotic syndrome in the children. Light microscope, glomeruli will normal in appearance. Electron microscope, diffuse effacement or loss of the podocyte food processes. So when they lose, they will open the junction with the tight junction between the capillary and the basement membrane, and there is leakage of the protein and the lipids. Now we go to the diabetic nephropathy. So what is the definition of diabetic nephropathy? It is a microvascular complication of diabetes. What is main manifestation of this are marked by albuminuria and a deteriorating course of the normal renal function, which eventually lead to the end stage renal disease. So it's a microvascular complication, start with the albuminuria, then there is deteriorating renal function, and eventually it turn into the end stage renal disease. In fact, they say the diabetes is one of the most important cause for the end stage renal disease in the adult population. And it is characterized by albuminuria, hypertension, and decreasing GFR. So, leading cause, as I told you, it is the leading cause of the end stage renal disease in the developed world, and the earliest manifestation is the albuminuria. And this albuminuria is known as the microalbuminuria, where the protein level is in a range of 30 to 300 milligram per day. Okay, it is more than 30 and less than 300 milligram per day. This is known as the microalbuminuria. And microalbuminuria is the characteristic earliest manifestation of the renal disease, diabetic nephropathy. and it is approximately in the type 1, 80% of the type 1 diabetes mellitus patient, and 20 to 20%, 40% of the type 2 diabetes mellitus patient. And in a range of 10 to 15 years, they develop nephropathy. And approximately 20 years after the diagnosis of diabetic nephropathy, 75% of the type 1 DM patient and about 20% of the type 2 DM patient develop end stage renal disease, and they require dialysis or renal transplantation. So look how common it is the in type 1. Because why it is so common in the type 1? Because type 1 diagnosed at a very early age, like 12, 13, 14 years. Okay. And when by the time he reaches to 20, 25 years, 80% of them will have this thing. And once the diagnosis is done by the age of 40 years, 75% patient of those will have end stage renal disease. However, the percentage is slightly lesser in the type 2 DM patient. But if a person of type 2 DM patient will, if he doesn't have the good control, he might develop at a very earlier age, and the progression is also a rapid one. So as we talk about a lot of proteinuria, so what do you mean by different definition? Normal albuminuria, when the albumin creatinine ratio is less than 30 milligram per gram of the creatinine. So this is the normal albumin excretion in the urine. When do you call it is microalbuminuria? When the spot albumin creatinine ratio is in a range of 30 to 300 milligram per gram of creatinine, or 24-hour urine albumin is in a range of 30 to 300 milligram per day. This is known as a microalbuminuria. Albuminuria, when the albumin creatinine ratio is more than 300 milligram albumin per gram of the creatinine, or the 24-hour urine albumin excretion is more than 300 milligrams. So we call it as a macroalbuminuria. While the proteinuria, when there is a presence of urine dipstick 1 positive, which is usually correspond to the more than 30 milligram per deciliter, it is proteinuria. And when you do the spot, it is more than 200 milligram of protein, and 24 hours urine total protein is more than 3. So proteinuria is all protein. But when we talk about the albumin, it is only about the albumin. So in the urine, you might have albumin, some globulin, some fibrinogen, or some other protein coming. That time you call it is protein. But when we talk about specific about the albumin, so this is the range for the normal, micro, and the macro. So albuminuria in a range of 30 to 300 milligram per day is called microalbuminuria. So how do you calculate this? You give your patient a jar and you ask him to collect the urine for 24 hours. So what he has to do, he has to discard his first morning urine. He doesn't have to collect that, okay, when he pass first urine. After that, he start collecting his urine in that jar until the next day morning urine. The next day morning urine he has to collect. That does not have to be discarded. Okay, so this 24-hour, and if you find the albumin level in between 30 to 300, we call it as the microalbuminuria, and it is very important because it predicts the development of clinical nephropathy. One positive is not enough in the low range. Okay, suppose your patient has got 35 milligram, you will not call it as a microalbuminuria. You will have another symptom, okay, to label it as a microalbuminuria. Standard urine dipstick detect total protein. Okay, this is total protein. So we will not call it as a microalbuminuria because urine dipstick is calibrated for all the protein, not for the albumin. An untimed random spot urine for albumin, creatinine, or protein creatinine ratio first morning void preferred. Okay, so first morning you have to not to be collect in the first morning. Okay, always do it in the, and 24 urine hours sample is more accurate to label as a microalbuminuria. So why this is very important, why we are talking about this diabetic nephropathy? Look at here. Uh, when we have a study in the 2012, okay, from 1993 to 2012, you have a very few patient, okay, where you have almost 2000 patient in the kingdom, entire kingdom, which were on the dialysis. But till the 2012, it reached to the 15,000 patient requiring the dialysis. Okay. Now, a recent study done by Al Sahli et al. In 2025, you see the prevalence of the CKD, chronic kidney disease, has been come to 4.76%. It seems like almost 5 in 100% are affected with the chronic disease. Okay. And majority of them are in the stage 3, like 3.5% of the total CKD are in the stage 3. And you see the, if the region wise you see, if you see the sex, males were more common than the female. And in the region you see the Makkah region has the highest, followed by the Riyadh region. And then you have, it is third to fifth most common cause of death in the different regions. So that's why it is very important to catch the diabetic nephropathy at the earliest stage, start treatment, make good glucose control, so that your patient should not go into the end stage renal disease. So what is the pathogenesis? Okay, complication, because it happens due to as a complication of diabetes mellitus, and that is mainly due to the hyperglycemia. So there are, one pathology is advanced glycation end product, age, advanced glycation end products. Okay, so glucose steroid metabolite like glycol, methyl glycol, and 3-deoxyglycol, they combined with the amino group of the intracellular and extracellular protein, and this reaction is non-enzymatic. They don't require any enzyme. This is continuously happening, and they form the advanced glycation end products, age. And this age will go and deposit at various places, and one of the most favored place for this age to deposit are the microvasculature of the kidney, retina, and the around the neurons. That's why the nephropathy, retinopathy, and neuropathy will go together. Okay, this is the normal process. Actually, this is a normal process. But whenever there is a high amount of glucose, there is a high formation of these derivatives. So there is more interaction and the more age formation. So they are chronically high and they cause more massive damage. Then there is also a receptor mediated effect due to the advanced glycosylation end product. Okay, so there is release of cytokines in the growth factors such as tissue growth factor beta or the vascular endothelial growth factor. This vascular endothelial growth factor is principally responsible for the vascular abnormalities in the retina, leading to the diabetic retinopathy, while TGF beta is the excessive deposition of the basement membrane material in the glomeruli. Okay, then also there is generation of the reactive oxygen species in the endothelial cell, causing more damage. There is also increased procoagulant activities, increased proliferation of the vascular smooth muscle cell. There is also extracellular matrix synthesis. This will also lead to the microangiopathy and the vessel injuries. The inflammatory cells, macrophages, T lymphocyte, endothelial cells, vascular smooth muscle cell, these are the cells which is principally affected by the age and age. Then there is non-receptor mediated effect. What is the non-receptor mediated effect? There is like type 1 collagen in the large blood vessel, decreased elasticity, so predisposition to the like there is like shear stress mechanism is disturbed and there is endothelial injury. Or then this is also bind to the type 4 collagen of the basement membrane, decreased endothelial adhesion, extravasation of the fluid, accumulation of the fluid. So this is also non-receptor mediated effect. So there is deposition of the fluid or fluid-like material inside the renal epithelium. So oral effect of the age can be receptor mediated or can be non-receptor mediated. Okay. So there will be, that will lead to the microangiopathy, vessel injury, and basement membrane thickening. There is another mechanism is activation of the protein kinase C. Whenever there is a hyperglycemia, there is de novo synthesis of diacylglycerol, DAG. These DAG will lead to the protein kinase C activation. Whenever protein kinase C get activated, they stimulate the vascular endothelium. Vascular endothelium get stimulated and it secretes the cytokines, especially VEGF, vascular endothelial growth factor. Then we have uh, tissue growth factor beta, plasminogen activator inhibitor 1, which is lead to the procoagulant effect, and that will lead to the microangiopathy. And these microangiopathy predominantly affect the kidney, retina, and the along the neurons. This the third mechanism is the increased susceptibility to the oxidative stress. So there is intracellular hypoglycemia. This will go to the metabolic pathway to form sorbitol. The sorbitol will go in the aldose reductase pathway with the NADPH to NADP formation that will lead to the formation of fructose. And these fructose will again contribute to the sustained hyperglycemia. So there is decreased level of NADPH. Okay, NADPH is tissue protective. So to convert sorbitol to fructose, there is NADPH is used. This decreased NADPH will eventually lead to the decrease GSH, glutathione synthetase hydroxylase enzyme. This hydroxylase enzyme is very important to prevent from the oxidative stress. So when this enzyme is reduced, so there is increased susceptibility to the oxidative stress. So your tissue will be increased susceptible to the oxidative stress. Now come to the morphology. So what is the morphological changes in the kidney in the diabetic nephropathy? So in the glomeruli, you have the basement membrane thickening, mesangial sclerosis, nodular glomerulosclerosis, diffuse glomerulosclerosis. In the vascular, you have hyaline arteriosclerosis. And in the tubules and the interstitial of the kidney, you have pyelonephritis, maybe acute or chronic with or without papillary necrosis, interstitial fibrosis, and tubular atrophy in the later stages. So this is all the structure of the kidneys can get affected: glomerulus, blood vessels, tubular structure, and the interstitial. And these are the manifestation you get. While in the glomerular, it is very important. Initially, it starts with the glomerular basement thickening, then mesangial sclerosis, then nodular glomerular sclerosis, and diffuse. So the glomerular region, you have basement membrane thickening, you have pass positive periodic acid shift. This is a special stain. You see that positive deposit in the mesangium, and more than 50% of the patient will show global glomerular sclerosis. And you have the nodules, and these nodules, nodular glomerular sclerosis, KW nodule, is a very characteristic of the diabetic nephropathy. Okay, so that's why I am taking it as a separately. There is, you see the spherical or globular or ovoid nodular deposition in the mesangium of the glomeruli. Okay, so this is mainly because of the acellular pink color extracellular deposition in the mesangium, which is known as the KW nodule or chemistryl Wilson nodule. Okay, and this is due to the marked increase in the mesangial matrix. And this nodule is a very diagnostic of the glomerular region or the diabetic nephropathy. So what is more higher detail of this thing? They are laminated, pause positive, which are situated at the periphery of the glomerulus, lie in the mesangium as a acellular, okay? There are no cell. Acellular hyaline pink color matrix core. They might be surrounded by patent capillary loops. So you may see some capillary loops surrounding the nodules, okay? And there is also some intracapillary glomerular sclerosis. So very important, hyaline pink color acellular deposition towards the periphery is known as KW nodule. So other lesions, you have incidative lesions. These are known as the fibrin cap and the capsular drop. So some say the fibrin cap is a misnomer because it does not contain fibrin. Instead, it has the hyaline membrane. So someone used the hyalinosis. But the fibrin cap has been used for a long period of time. That's why we still use the fibrin cap. So you got these three features: fibrin cap, capsular drop lesion, KW nodule. They are characteristic of the diabetes mellitus, apart from basement membrane thickening, mesangial sclerosis, and diffuse glomerulosclerosis. In the vessels, you might see the hyaline artery sclerosis. It can affect both afferent and the efferent arterioles. You may see the tubular pyelonephritis, interstitial fibrosis, tubular atrophy. So now we go to the classification of the diabetic nephropathy. So you have the class 1 is known as the glomerular basement membrane thickening. When the glomerular basement membrane is thickened more than 395 nanometer in female and more than 430 nanometer in male, this is known as class 1 diabetic nephropathy due to glomerular basement thickening. Class 2 is the mesangial expansion. This is more than 25% expansion in the mesangial matrix. 2A, mild mesangial expansion. 2B, severe mesangial expansion. Class 3 is nodular sclerosis, where you see the KW nodule. And class 4 is the global glomerulosclerosis, where you see the more than 50% of the glomerular lesion with the lesion from 1 to 3. You might see the glomerular basement membrane, mesangial expansion, nodular sclerosis, along with the global glomerulosclerosis. This is class 4. Now, this is the classification. Now we have the stages. Stage 1, hyperfiltration. This stage is usually characterized by the increased blood flow in the kidney, and that will lead to the early renal atrophy. Though stage 1 have some hypertrophy of the kidney due to the increased blood flow to the kidney. Then stage 2, glomerular lesion without clinically evident disease. You don't have any clinically evident disease, but you find there is either the glomerular basement thickening or the focal glomerular sclerosis or the KW nodule. Stage 3, you have the incipient nephropathy with microalbuminuria. So microalbuminuria start in the stage 3. Stage 4, you have the overt diabetic nephropathy, where you find the proteinuria, like nephrotic range of proteinuria, creatinine clearance less than 70 mole per minute. And stage 5 is the end stage renal disease, where creatinine clearance is less than 15 and creatinine is or more than 6 milligram per deciliter. So these are the stages, and that one was the classes. So global glomerulosclerosis in 50% of the glomeruli with lesion from class 1 to 3. Yes, you have the stage advanced diabetic nephropathy, stage 4. Nodular glomerulosclerosis. Yes, you have nodular sclerosis, stage 3. Mesangial expansion more than 25. Yes, mesangial capillary lumen, severe, stage 2B. Mild mesangial expansion, stage 2A. Just find the glomerular basement membrane thickening. Yes, it is stage 1. Okay. So this is what stage 1, 2A, 2B, 3 and 4. You have the class, sorry. Sorry, this is not the stage. This is the classes. I'm sorry. Okay. These are the classes. Class 1, class 2A, class 2B, class 3, class 4. And these are the stages. So how do you diagnose or the screen? Simple. you have to either you look for the spot urine albumin creatinine ratio, or the more accurate one is the 24-hour urine collection to look for the albuminuria. Maybe it is micro, macro, or proteinuria. Or in emergency section, you can just see that urine dipstick. If your patient is diabetic, you find the urine 1 positive, you might ask your patient to have a follow-up with the 24-hour urine collection and to look for the microalbuminuria. So why it is important? Because like the glomerular filtration GFR, you have what is the GFR and the stages, but that might be normal or sometimes affected. Okay, but proteinuria, albuminuria, you have like normal proteinuria, microalbuminuria, or macroalbuminuria. So sometimes you have normal protein excretion, okay, and your glomerular filtration rate is also normal, you have in the green category. Okay, so this is a low risk to develop renal failure or chronic kidney disease, especially if you are mildly decreased 60 to 90, but your albumin is in the normal range, you are in the green category. Even though your albumin is the normal range, but your GFR is moderate, mild to moderately decreased, you have got the moderate risk. And when you in the orange and yellow, your risk is high and the very high risk. And you see, even the glomerular filtration rate is normal, but you have got the microalbuminuria, you have the moderate increase of the risk of the CKD, and you have the severe A3 like macroalbuminuria, even the glomerular filtration rate is normal, but you have high chances of development of this thing. Okay, and you have very high and the highest risk. This is just for you to understand when you screen a person with the help of urine albumin and glomerular filtration rate. Even someone asks you, you are mashallah, you are a doctor studying in the medical college, your relative might give you the report of the urine and protein and all those things. You look for this, look for the GFR, look for the protein values, okay, and you look for their history, and you can guide them, you can guide your grandparents, your parents to with this chart. This is very helpful for you to understand the progression of CKD with the help of GFR and protein level. What are the treatment goals? You have to have your patient is a diabetic, so the base thing is the lifestyle change, strict control of the blood sugar, strict control of the blood pressure. You have to the like, and you need to blind renin angiotensin activity system blockade with the help of ACE enzyme inhibitor. So what are those? We have captopril. Captopril causes dry cough. You can use another thing like ramipril as our patient was using. You can also use ARB angiotensin receptor blockers such as losartan. Okay, you also use lipid lowering agent, and you other also risk the other cardiovascular risk. So diet control, high exercise, weight control, strict control of the blood glucose. If patient has the hypertension, strict control of the hypertension, and the treatment with these two group of drugs. Earlier diagnosis and the earlier start of these two group of the drug to slow the progression of the chronic kidney disease. Okay, so this is our references. Okay, so this is what the additional resource you might find another lecture. Okay, but today I try to get some important point from those lecture to incorporate in this lecture. Okay, but if you want to know something more, you can go through the additional resource. But if someone don't go up the additional resource, because I have already imported the important slides from those lecture to in this lecture. Sorry, here Dr. Akbar's number is there, but he is not here, so you can contact me. Okay. So, any doubt?
Doctor,
Yes.
I have a question, please.
Yes, please. Go ahead.
In page 7,
Hmm?
In nephrotic syndrome, we say when decreased colloid osmotic pressure,
Yes.
so then decrease in plasma volume and then decrease in glomerular filtration rate.
Yes.
And we take before when decreased colloid osmotic pressure, so suppose glomerular filtration rate is increased because the reverse power is decreased.
Yeah. So what I explain you over here, okay? That is a compensatory mechanism, okay? So what happen whenever there is a decreased colloid pressure and the fluid is going to the interstitial tissue? So there is a decreased plasma in plasma volume, okay? Plasma volume is, so what happened? There is a decreased GFR and this system get activated and that will try to increase the GFR, okay, by increasing more water and sodium retention, okay, or absorption. So that will try to in turn try to increase the GFR, but here there is problem here, structure abnormality, that what you are talking about, that is the normal physiological mechanism. But here we have already ultrastructure abnormality. In that case there is accumulation of more and more edema. But suppose if your patient is normal, whenever there is a decrease colloid pressure, that lead to the decreased plasma volume initially, that initially will lead to the decrease in the GFR, that is activation of the aldosterone mechanism, that will cause sodium and water retention, that will increase blood pressure as well as water in the plasma. So plasma volume will get increased and the glomerular filtration will come back to the normal. That is the normal physiology. But this is in the pathological condition that will lead to the excessive edema. Okay,
Okay, doctor, thank you.
you understood? What you are telling is correct. That is, if you forget about this part, okay, just go to over here. So decrease in the plasma volume, decrease GFR, increase aldosterone secretion, sodium and water retention, and that will lead, come back to the normally increase plasma volume, normal plasma volume, and the normal GFR. This is the normal compensatory mechanism. But when there is the ultrastructure abnormality, this compensation will not act. Instead, there is excessive fluid accumulation. Okay?
Okay, doctor, thank you.
Okay. So, any more questions? No? So, if there are no questions, you can go through the lecture again. If you have difficulties, you can ask me. Assalamu
Thank
alaikum
you,
wa
doctor.
rahmatullahi wa barakatuh.